Hi, everyone, and welcome to the January 2023 Case of the Month with the CNS. I'm Rushna Ali, and today we'll be talking about management of catheter tip granulomas after pain pump placement. So we have a case of a 40-year-old woman who has a past medical history of degenerative scoliosis and a T10 to pelvis fusion, as you can see from the CT scan over here. She subsequently underwent pain pump placement for severe low back pain. This was implanted outside of her current residence state after failing a trial of spinal cord stimulation and several other conservative measures. 5 years after pump placement, she presented with worsening pain. And at the time of her presentation, the pump was infusing a combination of hydromorphone and fentanyl at pretty high doses. She had required increasing doses of medications due to loss of pain control. The CT myelogram that was performed as part of this evaluation showed a catheter tip granuloma at T7. This can be seen in the dorsal part of the spinal canal just behind T7. And on this axial cut, you can see it's slightly paracentric to the left side, effacing the CSF space and causing spinal cord compression. So in the absence of neurological deficits, treatment of catheter tip granulomas includes temporarily stopping the pump, switching the pump medications, or a catheter replacement. However, if neurological deficits are significant or persist despite these measures, then a laminectomy and intradural resection of this mass can be considered. Since in this case, stopping the pump medication did not resolve the issue, it was decided to replace the catheter. Positioning and incision for this type of surgery includes a lateral decubitus position on a beanbag with the abdominal pump side up, as you can see from this figure. A linear incision is centered between the costal margin and the pelvis for pump placement, so the pump doesn't dig into the ribcage or the pelvis when the patient is upright. For the lumbar catheter insertion, there's a paramedian linear lumbar incision that is made. Fluoroscopy is used throughout the case to verify levels and intrathecal placement. For the lumbar incision, one should dissect through the subcutaneous tissue, expose fascia, but do not open it because you are going to need an intact fascia to be able to anchor your lumbar catheter to. A TUI needle is used to access CSF space under AP and lateral fluoroscopy. You can see the red arrow points to the TUI needle entering the CSF space. Once CSF egress is seen, intrathecal catheter is passed to the desired level, about 1 to 2 levels below the level of the granuloma, once again under fluoroscopic guidance. The prior catheter is then removed. The new catheter is anchored to the fascia using manufacturer-provided anchor and stitched to the intact fascia so it doesn't retract. And this is an example of this anchor that is used to hold the catheter in place. The catheter is then tunneled to the abdominal incision and connected to the pump. In this particular case, there were no immediate changes in the patient's preoperative symptoms. However, she reported improved pain control over 1 to 2 weeks. Follow-up MRI imaging 3 months after catheter replacement demonstrated near resolution of the catheter tip granuloma, as you can see on this axial MRI performed at the T7 level. And her preoperative symptoms of numbness improved, and she reported good low back pain control at 3 months. Some pearls and pitfalls to remember during catheter replacement: do not tug hard on the previous catheter since the tip might be stuck within the granuloma. If unable to remove the previous catheter, you can either leave it disconnected from the pump and clipped at the end, so there's no CSF that continues to flow through it, or proceed with a laminectomy and resection of the granuloma. particularly if there are neurologic deficits. In non-urgent situations, gradual weaning of opioids by reducing 10 to 25% of the dose per day with supplementation of low-dose oral opioids can be performed, especially if the catheter is stuck and cannot be safely removed, which allows for the granuloma to resolve on its own. So in conclusion, catheter tip granulomas are rare and occur in about 2 to 3% of patients with an intrathecal catheter. They're associated with an inflammatory response, most commonly seen from morphine infusion, but have been reported with combination, non-narcotic, and baclofen infusions as well. They're typically associated with increasing pain, necessitating increasing doses of medication without improvement in pain symptoms. Neurological deficits are rare, but can occur from focal spinal cord compression. If there are no neurological deficits, treatment includes temporarily stopping the pump, switching pump medications to non-narcotic options, and discontinuing combination medications or catheter replacement. If neurologic deficits are significant or persist despite the above-mentioned measures, then a laminectomy and intradural resection of mass can be considered. If this is performed, then postoperative worsening of symptoms is common, but usually temporary because the mass can be densely adherent to the spinal cord, and therefore only partial resection is typically performed. Thank you very much and stay tuned for more cases. Thank you.